And today I'm very happy because we have like an excellent speaker, Dr. Ram Rajagopal. Like I didn't get an opportunity to train under him. I was talking to him the same thing. Like as a postgraduate student in Kasturba Medical College, I met him. So during that time itself, like I was really wondering the way he the makes the slides, the animations and all. I think I've seen first time in his slides, and as postgraduate students, we were trying to decode his slides and then was trying to learn because he used to share the slides that time. And I think even nowadays, almost all those who are doing ABG presentation, the basic steps are by Dr. Ram Rajagopal. Majority of them may not be putting his name, but I can say all those steps are described by sir. I think maybe in 2005-6 that time. So he's an excellent speaker. I don't think he needs any introduction. One of the senior most critical care physician in uh, India, and the former ISCCM president, and now he is chief of critical care medicine in Sri Ramchandra Medical College, Chennai. So, sir will be giving you an overview about how to approach the toxicology patients. And whenever he asks a question, you can put your answers in the chat box, and we will inform the sir like how is your response. So we would like to keep it as an interactive session. So over to Ram Rajagopal, sir.
Thank you, Anup. Thank you, Anup. I hope I'm clear.
Yeah, perfectly all right, sir.
All right. I'm getting a little echo from you. Maybe you'll need to turn off your mic. Okay. All right. Today's talk is going to be on the general approach to toxicological problems. Okay. And I think I'm projecting it right now. Yeah. Okay. And this is not going to be a very typical kind of lecture that you would expect. Very typically, when we are talking about these kinds of issues, most people would expect me to go through these toxidromes. But I know most of you probably are reasonably familiar with the toxidromes. It doesn't make any sense for me to keep developing on that. On the other hand, what I would like to focus is on to discuss very specific issues related to a critically ill poison patient. And among the things that I would like to encourage is when you approach such a patient, obviously we need to be thinking on one's feet. When you're dealing with life threats, you need to be thinking at the same time. And I hope that some of these slides or some of the parts of this discussion will allow you to understand what I'm trying to come to when I'm going through this process. There will be a lot of common procedures that we perform in these patients. And I just want to debate some of the value of some of these procedures. So with that as the background, let me just start over here and say, here you have a farmer who's admitted with respiratory distress with an unknown poisoning, probably a pesticide. The fact that I'm giving a history of a farmer who's taking a pesticide very clearly is agitated and distressed. And as we probably recognize, let me just get this down. He's got a heart rate that is low, his blood pressure is low, his respiratory rate is high, he's very desaturated, even despite the fact that you're using a non-rebreather face mask on him. The pupils are constricted, he's salivating and smells of kerosene in the emesis. There is a lot of diffuse lung crackles and a wheeze. So I would ask you a very simple and reasonably straightforward question over here and say, which of these 4 reactions is what you're going to have? Are you going to say, okay, you've told me he's a farmer with maybe a pesticide and he's giving me classic findings and I know that condition well and I'm going to start proceeding with the treatment of this patient? Or you're going to say, oh, let me get some basic electrolytes and ABGs and things like that in the first place. Or you'll say, I need to stabilize this patient and then I can plan my therapy. Or you would be very sophisticated and go around and say, oh, let me get some toxicology screen before I perform any actions on this patient. Okay, I suppose there is a whole bunch of answers that have come already. If you really look at it, yeah.
Majority 3 is the answer.
Majority will say, yeah. I don't think it is a totally inappropriate kind of an answer. Let me just go back to that. I don't think it's a totally inappropriate answer. But to me, this is a classic toxidrome. I don't think I need to even be mentioning anything. And along the lines of this toxidrome that we very clearly understand is going to be compatible with an organophosphate poisoning, it is fairly okay under these conditions to initiate the therapy that you're talking about over here. And the therapy under these conditions is going to be atropine. And the process of stabilizing the airway, breathing, and circulation is completely also appropriate, but may not be something that you would do later. Let me stabilize and then plan is not necessarily an action. Let me also treat this very visible toxidrome. The reason that I'm bringing this up is very often when people are approaching a patient in a toxicological situation, we take one of these two approaches. We can take a very Western kind of approach and say, I don't want to focus so much on the history and clinical examination. I would rather have a toxicology screen. It's a very expensive and probably a frankly delayed kind of an approach. But us, on the other hand, we do focus on the history and clinical toxidromes. And in this particular situation, I just brought out a very simple, straightforward toxidrome, where the value of laboratory testing and a toxicological screen is absolutely, frankly, useless. And we can very easily start performing the right actions on these patients. You were not totally wrong when I said, when you're thinking on your feet, basically you're giving thoughts, but at the same time, you're guaranteeing that the patient doesn't die. So many of you answered that you will go ahead with the airway, breathing, and circulation kind of options immediately. And that is completely appropriate. But as I said, in this particular situation, and we know when you're going to organophosphates, we always talk a lot about the role of oximes and things like that. But we keep forgetting that the primary antidote in organophosphate is atropine, and the appropriate administration of atropine does make a big difference in terms of the outcome. And in fact, in that particular patient, when I was looking at it, okay, a lot of the hypoxia can be probably treated aggressively with the atropine. The tachypnea probably will settle. The patient may very significantly and rapidly settle, and that itself will be an appropriate action in terms of stabilizing your airway, breathing, and circulation. So that is something that we do. We always do that. And my own step is, I would, rather than look only at the ABCs, there's an old ACLS algorithm which used to focus on this, which will also say, make sure that if you have airway, breathing, circulation as a part of your compromise, that you also provide the patient with an appropriate amount of IV access, because you might need to give medication, atropine in this particular situation. Make sure that you're giving them oxygen at the appropriate level, and a minimum monitoring. And today, monitoring means your blood pressure, your ECG, and probably your oximetry at any given stage. And once you've gone through that, look at your vital signs, and then consider the other two aspects when you're looking at a toxicological patient. Look at the disability and the process of potentially eliminating the toxin as well. So A, B, C, D, E is all the way we go, with IV oxygen monitor and vital signs being interspersed in between. And this is what I would call thinking on your feet, making sure that the patient doesn't die before you, come to some kind of a diagnosis and therapy. Okay, let's go on to another case. Okay, here again, you can punch in your answers whenever you want to. A 52-year-old man was drunk when he had an argument with his wife. It's not me, I'm older than that. He grabbed some household bleach solution and gulped it down. He sputtered and spat and complained that it was tasting terrible. His voice was extremely hoarse. He's drooling, he's salivating, but he's breathing very comfortably. His saturation is 96% on room air. When you auscultate his chest, there are no crackles, no wheeze, no stridor on auscultation. But when you do a laryngoscopy, you can see corrosive burns of the pharynx. But the cords, the glottis all seem to be very stable, and there doesn't seem to be any associated edema. What would you or wouldn't you do at this point in time? Questions?
What you would do and you wouldn't do.
What would you or wouldn't do? That's all I'm going to ask you. Okay. Okay. Can I look at some of the answers? I'll probably try and look at some of the answers over here. Okay. Absolutely no lavage and no forced emesis. Somebody says no gastric lavage seems to be a common one. Somebody wants to do an ABG, which doesn't seem very logical. Okay. Edema can increase, and very few people actually on the balance seem to focus on the issue related to the airway. Listen, I put the topic right on top and I said airway, and then I gave you a topic. Everybody is focusing on the fact that you didn't want to do that. Here is a very classic situation where you have sufficient signs in a guy who's taken a corrosive that he will potentially hurt himself. He's got significant pharyngeal bleed, wall pharyngeal erosions almost all the way to the glottis. Okay, it may be that is not it's sparing some of the glottis, and this is a kind of a situation where the guy is drooling, he's got hoarse voice, is potentially somebody who will compromise his airway. And this is something that, again, many of us seem to miss on a very regular kind of a basis. Okay, we should recognize that as much as we need the airway under very clear-cut circumstances, in the majority of toxicological situations, the patient is unconscious and as a consequence of the primary toxin itself, or he may be hypotensive and may be having a cerebral hypoperfusion, which will cause his airway to obstruct. And in many of those situations, you can probably open it up with a simple nasopharyngeal or oropharyngeal option. Okay, we need to remember that there will be a lot of consequences of this kind of a closed airway. Remember, hypoxia is something that can be compounded under these circumstances. And here on this particular patient, we don't have any one of these immediate threats. But we have to remember that while you are providing this patient with the appropriate amount of oxygen, monitoring it in an appropriate way, it is not totally inappropriate to provide a little bit more FiO2 than you need to under these circumstances. And I feel that under most of these circumstances, either a non-rebreather face mask, which provides you with a 100% reservoir, is a very relatively a safe kind of an option that you could use. But in addition to that, in particularly corrosive ingestions, this concern about drooling, hypersalivation, and hoarseness is a strong, with the evidence of a pharyngeal burn, is reasonably strong evidence that this patient would probably end up with a compromised airway. And it may not be totally inappropriate to prophylactically intubate this patient, even though he is awake at this point in time. So just be very clear about that. The one other very peculiar airway problem that we face under these circumstances is the supraspasmal, the PPD kind of hair-dye related airway edema. Again, over here, you have to remember that waiting too long can make it far more difficult to intubate these patients. Many of these supraspasmal, even though they look very edematous, we've always found it reasonably easy to go ahead and do oropharyngeal intubation. But if you wait too long, you potentially can create a problem where you need to end up with a surgical airway and a total mess. So I think we need to understand that the need for a definitive airway in many of these patients is not just in the one who is not breathing, the patient who is comatose and potentially requiring an airway protection, or for that matter, for managing aspiration or anything of that sort. But we should be very careful about worrying about existing or potential airway obstruction. Potential airway obstruction is classically illustrated in this particular situation where I took a patient with a corrosive poisoning. And I think we should anticipate that before we look at airways and management in these kinds of situations. Okay, let's go on to the next part of it. Okay, I'm going to give you another example. Maybe we can, it'll be nice if I could have a verbal interaction, but I don't think it'll be easy on this large group. Okay.
Verbal interaction is possible, sir, but only 2 to 3% we can.
Yeah, can we pick on anybody? You pick somebody. Yeah. You pick somebody. Let them read this out, and then go ahead.
Can you please like volunteer, like as usual during our interactive session? Can you please raise your hand? Please raise your hand. Yeah, one person has already. Shweda, okay.
Okay. Can you turn their mic on and maybe ask them to read it and then proceed with this?
Shweda, you
hello, good evening, sir.
Yeah, you can answer to him.
Okay.
Yes, sir. Good evening, sir.
Go ahead. Just read this and just proceed with what you're saying.
Here is a patient with unknown overdose. Is very tachypneic with a respiratory rate of 45 per minute, nasal flaring and accessory muzzle use. Decided to intubate as he seems to be fatiguing. Which precaution is appropriate? Rapid sequence intubation.
Look at your blood gas also at the same time. Okay, you have a blood gas that is available at the same time.
Sir. Yes, okay. Sir. With an FiO2 of 0.21.
That's on room air.
Yeah, on room air, his PO2 is 114, PCO2 of 14, pH of 7.28 with a bicarb of 8.
Okay. All right. What do you think is the potential? What do you think is the poisoning under these circumstances? What do you see on the blood gas that gives you some kind of a clue as to what is going on?
Sir, he is in respiratory acidosis, sir. I'm
Is he
sorry,
in
metabolic acid. No, metabolic acidosis, sir.
Okay.
He's having
Metabolic metabolic
acidosis.
acidosis with a bicarbonate of 8. Okay. All
Yes,
right.
sir. Yes, sir.
Is that pH looking too good for you?
No, sir.
The pH is looking appropriate for a bicarbonate of 8.
1
You
minute,
and
sir.
me.
Yeah, I'll just calculate. Yes, sir. 1 minute.
No,
Sir, sir,
12
I don't
plus
even
8.
need for you to calculate, but basically let me tell you that
Yes, sir.
with a bicarbonate that is that low,
Yes,
okay,
sir.
for a
Yes, sir.
metabolic acidosis, the pH
Yes, sir.
is a little on the higher side.
Higher side.
So
Yes, sir.
very visibly there is also a respiratory alkalosis.
Respiratory as yes, sir.
Alkalosis. Respiratory
Asclerosis. Yes, sir.
alkalosis. Okay,
Yes, sir.
which is the
Yes,
reason
sir.
that the pH is being pushed in the wrong direction. That
Yes, sir.
combination is very typical of one particular poison. What is it? Can you tell me?
there are so many answers in the chat, sir. People are answering.
Yeah, I don't, yeah, anybody got the answer in the sack? There's 37, 38, 41, 42. Anup,
Yes,
it's
sir.
for you to look
Yes.
at them. What do you think?
Salicylate.
Yeah, doesn't it sound
Yes.
like one very,
Yes, sir.
very typical? Okay,
Yes, sir.
I'm not in real life seen anybody taking that many salicylates to create this kind of a problem, but it's a very typical kind of a situation, but irrelevant. Okay, so
Yes.
he's
Yes.
got a severe metabolic acidosis and
Yes.
he's got a superimposed respiratory alkalosis. So with
Yes,
that as a consideration and the fact that he may be fatiguing,
Yes.
what among the choices that I'm asking you to make, which precaution is appropriate? One or more of them would be valid. Just try to tell me which one. You just pick, and then I will go through my discussion, and then when we come to the specific points, we will talk about it.
Kamal also you can help Shweta. Kamal, you can. Kamal, are
Sir,
you? Yeah, Kamal, please.
so pre-intubation bicarb with RSI, sir?
Pre-intubation bicarb. Is that a very traditional thing that you would do? Why would you give a bicarb? Why can't you just intubate the patient and ventilate the patient? Wouldn't it be enough?
No, sir.
Why not?
Sir, because we need to take care of the the metabolic acidosis which is there. By intubating, will only be taking care of the respiratory components.
In fact, the other way around, when you are going to intubate and if you sedate or paralyze and you hypoventilate this patient, it's very likely you will not achieve the same amount of ventilation that the patient is spontaneously doing. Okay. And as a consequence, it is very likely that you will make the acidosis a lot worse. Okay. This is very typically, this is not very typically what we do under routine circumstances. The need for a rapid sequence, the need for an experienced intubator, and the need for a pre-intubation bicarbonate makes a lot of sense because you want to abbreviate the period of time that the patient is being hypoventilated. Okay.
Yes, sir.
And this is very peculiar for many of these acidotic conditions that you will face under the circumstances. It may not be true for just say common chronic renal failure where you're going to intubate or something like that. But under most circumstances, this would be a very logical kind of a thing to do. Okay. And again, as you notice, after the intubation, what have I done? Would you agree on that? 10 ml per kg is what I'm saying.
You say you're hyperventilating the patient.
Not just hyperventilating, but I'm also giving them a large tidal volume. This can be debated. This can be debated, but it is not something that you will persistently use, but you would probably use this as a short-term kind of a benefit. The point that I'm raising, thank you. Okay.
Yes,
so
sir,
the point that I'm raising with this particular example is the fact that when you are intubating a patient with a toxicological problem, it clearly depends on the circumstances in which you're going to be dealing with this patient. Obviously, somebody who's got a very severe metabolic acidosis and the primary etiology of the poisoning is causing that metabolic acidosis, in addition to which it is also stimulating the respiratory center and is making the patient develop a respiratory alkalosis. He is compensating to some extent for the acidosis. If we try to decompensate him in the process, we probably will hurt him. And that is the basic idea that I wanted to bring in. So the idea of a rapid sequence intubation is not something that I need to express to you. But again, there are certain poisonings under which the use of a neuromuscular blockade should be very carefully thought about. Digoxin classically can be associated with severe hyperkalemia, as could be some of the other alkaloid poisonings that could create a problem in hyperkalemia. Remember, you have cholinesterase deficiency with OPCs, and the selection of your neuromuscular blockade is also something that you should give or pay a little attention to in the process of attempting to intubate these patients. As I said, the routine management of airway issues, of respiratory depression or the hypoxia can be managed in the same way as you would do under other circumstances. You can always ambu back the patient up with a high amount of FiO2, and you don't have to worry about the depressed respiration because any amount of ventilation is going to be beneficial. But when you're dealing with a tachypneic patient who has an associated significant baseline metabolic acidosis, particularly these are the drugs that you'd worry about: methanol, ethylene glycol, salicylates, okay? And the salicylates also stimulate your respiratory center. We need to be very clear that we need to give some attention to this. And this is the usual difference under these circumstances, that the profound acidosis and the pH protection of the respiratory alkalosis would say that you need to intubate this patient as fast as is possible, okay? Not with your routine paralysis, not with your low tidal volume, okay? But we need to do something to manage the pH in a appropriate way. So the combination of all these rapid sequence intubation, probably large tidal volume, 10 to 12 ml per kg in the initial phases, not as a persistent kind of a process, okay? And the use of bicarbonate both pre and post intubation is probably something that is usually recommended. In fact, I've seen guidelines that talk about safe intubation under these circumstances, which usually recommend somewhere between 1 to 3 ampules of soda bicarb pre and post intubation to avoid sedation to just before the intubation, to optimize the first pass success with rapid sequence options using the high, this is basically the kind of process. And remember that we don't like to keep somebody at that 10 ml per kg for a very long period of time, though theoretically we are understanding more and more that normal lungs will tolerate this to some extent. We don't have to be that fixated on that 6 or 8 ml that we have always been talking, but sooner or later you'd like to bring the airway pressures down over a period of time. And for that, under these conditions, the three toxins that I was talking about are all imminently dialysable toxins, and we need to do something initially to minimize the risk related to the persistent acidosis. So this would be a good way to look at it. What I'm trying to say is many of the principles of airway breathing and circulation will be identical to many other circumstances, but under toxicological kind of circumstances, depending on the agent that you're going to be dealing with, you probably need to make some adjustments in the way in which you are handling this patient. Okay. So likewise, when you talk about the circulatory status, when you have a patient who comes to you hypotensive with a poisoning, our approach to the management of these poisonings, of this hypotension, is not going to be very different from what you would do under many other circumstances. But occasionally, you may have very classically refractory circumstances. And I'll give you the next example with a case over here. Some of these cases that I'm going to give you are extremely obvious. It is not the diagnosis that is very important, but it is the understanding the principles in the management of these individuals. That is why I highlighted some of these cases. So again, here is going to be a reasonably straightforward case. Anup, again, can we ask for volunteers and somebody else to pick up on this and proceed with it?
Gautam, can you unmute and talk? And Pratik also. Pratik Jain and Gautam, are you there? Please unmute and talk.
Pratik, why are you hanging around me, man? Stay away.
Please talk, Pratik. Hello?
Hello. Good evening, sir.
Yeah, please.
Pratik.
Good evening, sir. Sir, the question 4 is the low blood pressure, sir. The 20-year-old girl has taken all her mother's blood pressure pills, is unresponsive, hypotensive, tachypneic, sir. Saturation is undetectable on pulse oximeter.
Well, the pill has been identified as a beta blocker. Okay, fine. Very easy.
Yes, sir. Appropriate and effective additional therapy would include 3 ampules of IV calcium gluconate, second changing noradrenaline to adrenaline, insulin 6 units bolus, infusion started at 6 units per hour, or insulin 60 units bolus infusion at 30 units per hour, sir. So for beta blocker toxicity, first we'll go for calcium gluconate, sir.
Okay, tell me what else we want to do. So you would want to use calcium gluconate is your choice. That's about it.
Yes, sir.
Okay. So the remaining are all wrong.
And we want to, sir, keep the MAP also higher to 65, sir. So we may have to give some change from noradrenaline to adrenaline, sir.
What is the advantage of noradrenaline to adrenaline under these circumstances?
So inotropic action will be there, sir, but we may have to give glucagon also,
of them,
sir.
Does noradrenaline have no inotropic action?
But sir, adrenaline will have more, sir.
Not necessarily true. A higher dose of noradrenaline will do that, but additionally, what is your?
It will give tachycardia also, like sir, it will improve the heart rate also. More.
Okay, you're hoping that it will do, okay. Yes, sir. But is it possible that since you have a severe beta blockade, it doesn't even matter?
Sir, actually, glucagon is not there in the option, sir. So
glucagon is not in the options. Do you have glucagon routinely available?
No, sir.
Okay. Do you know the dosing of glucagon?
No, sir.
Okay. Because very routinely, as I've seen, we don't find enough glucagon to be administered. Okay. So if glucagon is not there, calcium gluconate seems to be your only option. Yes, your logic about using adrenaline over noradrenaline, I will buy it. Okay. I would say adrenaline may have a greater tendency to provoke a tachyarrhythmia. Maybe it is worth trying. Okay. I'm not going to say it is a better inotrope or is likely to be more effective, but it is worthwhile. What about these two things? Why I don't have glucagon available? You're completely correct that I would have raised a kind of additional concern about using glucagon. But what have I thrown in? I've thrown in insulin at different doses. What is the value of that? If you are not okay, you can leave it out. If somebody else is willing to answer, we can look at it. Anup, you can look through the answers and see if anybody's answered it.
Yeah, Rijoy, can you just unmute and talk? Rijoy, are you there? Others also can type.
I'll see if there's anything.
And give the reason also. Which dose of insulin are you going to opt?
Yeah. Many people say high dose insulin. The question is, which is the high dose insulin? For most of us, even 6 units, that is 1 unit, 0.1 unit per kg per hour, is typically what we would use under ketoacidosis kind of situations, right? So is that a high dose insulin, or has it to be much higher than that? Insulin, high dose insulin euglycemic therapy. Everybody's got that. So somebody's put down 60 units and 60 units. I think that is what we need to recognize. Okay. Please understand, when you have, this is an example that I'm taking of refractory hypotension in a situation that is classically illustrated over here with a beta blocker overdose. Okay. So in this kind of a situation, the very routine processes that we will perform of adding an adrenergic agent will naturally be something that is not going to be very effective. So under these conditions, we need to be able to produce the inotropy or cause the heart to pump a little bit harder using alternative mechanisms. And one of the usual recommendations is when you're beta blockaded quite severely, you can still go through other alternate mechanisms that can produce the inotropy, glucagon being one of the mechanisms, but even that acts through the same kinase mechanisms as the beta adrenergic, as the adrenergic stimulation occurs. But it appears that insulin works through a completely different kind of set of circumstances. Insulin works in two ways. Number one, it activates another kinase system that can initiate a calcium transport into the cell and can improve the inotropy by itself. And the second thing is insulin can also work very effectively by the fact that it can mobilize glucose into these cells and as a consequence can provide an energy source. And a combination of improving the energetics of the cell and of the alternate pathway through which the insulin works, it seems like it can be reasonably effective in overcoming the issue related to beta blocker, beta blockading or adrenergic blockading that you will have. So please remember that the dose that we use typically for this kind of effect to occur is not what we would use as quote unquote high dose like we would use in ketoacidosis, okay, but rather in 10 times that kind of dosing. And along with this, as somebody had always suggested, you have to have a euglycemic clamp in the sense that you need to be injecting large quantities of sugar. It's usually surprisingly reasonable kind of sugar that you will be needing to use under these circumstances. You probably need an infusion of say 25% dextrose at the same time to try and maintain the patient in a euglycemic state. And this is usually the way in which we would handle it. Again, as I brought this example, it is an illustrative example of how you would treat beta blocker overdose, okay? But at the same time, it is also an illustration of the fact that when you're dealing with the airway breathing circulation issues in a poisoning patients, that sometimes you need to step out of the normal kind of boundary of saying, oh, I've already pushed my adrenaline and noradrenaline, now I'm adding vasopressin to the maximum amount and I'm not getting any benefit. We need to think of alternate mechanisms. And when we think of alternate mechanisms, again, my suggestion is, at least under our circumstances, think of the things that are available. Glucagon is, frankly, yes, it is a worthwhile kind of a process. Nobody has ever done a comparison between glucagon or insulin in terms of the therapy. Nobody has even shown that insulin therapy at this kind of a high dose affects your outcomes in a direct kind of a fashion. But it is one of the options that we have under these kinds of very difficult situations that we will face. So this is just an illustration of the three concepts that we had. Airway being differently managed, where you need to look at certain situations where you need to put it in prophylactically. I took the example of corrosive poisoning under these circumstances. The second thing was in breathing, when we saw that patients who present with tachypnea and a very significant acidosis, that we need to look at alternative ways in which you can guarantee that they don't decompromise during the process of intubation. So the rapid sequence option, along with pre and post dosing bicarbonate, makes a lot of sense. And in the third situation, we talked about the circulation and the low blood pressure. We're talking about not just going around mechanically and saying, I gave the fluids, I gave the calcium, I gave the adrenaline, but the patient didn't get better, and that's our end. Because you have another option of thinking of it in a very different way. So the intent of these three or four different questions was basically to focus on these ideas of how you change your routine management under conditions of poisonings that you need to be dealing with. Okay, let me just go on with my next slide. All right, so this is just an explanation of the refractory hypotension. We're talking about the euglycemic insulin clamp, which is basically what I was dealing with over here. The next aspect that we come on to is to look at the neurological status of the patient and neurological stabilization. We have to realize that stabilization of the neurological status and many of these situations has to be customized to some extent. We do worry about the seizures and appropriate neuroimaging in some of these patients. But before we go on to those in any specific detail, maybe I need to ask you about what you normally worry at about 7 o'clock in the evening during these COVID times, your cocktail, effectively. Okay. Yeah. Anup made me do this lecture and he told me I can't sit over here with my beer in my hand. So I'll only have to drool over what I have in my projection. Okay. So the question that I'm going to ask about your coma cocktail is it should always contain sugar. That is, if you like your cocktail sweet, that's the best thing that you can do. You should add a little bit vitamin so that for all the damage that you're going to do to your liver, the vitamin B will make a compensation. Or in this particular situation, getting a little bit more serious, we should probably use a little flumazenil or naloxone, which is the components that you would like to have with a reasonable certainty. Let's see what our answers are. Okay.
Can anyone unmute and talk? Rejoy, are you there?
Yeah, Rejoy seems to say 60 units or 6 units, but 60 units is what we want.
Rejoy, you can unmute and talk. Yeah, please.
Hello, sir.
Yeah.
Doesn't matter. So, yeah, I can't see your face, so you're quite okay to make a mess of it. I'm quite okay with it. Unless Anup knows you and probably will take revenge on you or something like that. I don't know. Okay, which one do you want to pick?
Sir, I go for basic sugar syrup, sir.
Okay, you okay. You want to give it as intravenous glucose. Is that what you want to do? You want to do that with a certainty. You don't believe that thiamine is necessary. You don't believe that flumazenil and naloxone should be considered.
Sir, after that, I will go for flumazenil.
You can also give me an answer and say, I don't want any of these to be used at all. Is that acceptable also? Or do you want to still give the dextrose, or you want to add the flumazenil? Which one do you want? So the patient is comatose, unknown poisoning, okay, right now. And these are the kinds of options that we have. It's very typical in the past that we always talked about this famous coma cocktail. So which component of the coma cocktail is something that you would like to have? That's the question that you asked. You said sugar syrup. Is that your preference?
Sir, before sugar, I go for thiamine, sir.
Okay. Because it's the be-all of life, okay? I like my own jokes and I laugh at it myself, but I suppose we need to sit and explain that a little later.
Others can also give your opinion. Sriram, you want to add something?
Yes, sir.
Anybody? Yeah, please.
Sir, good evening, sir. Sir, I would like to give thiamine before sugar, sir, because it might be alcohol causing Wernicke's encephalopathy.
Okay. Well, all of us are traditional thinkers over here, right? Okay. Has there been proof that any of these really make a difference in terms of outcomes?
Sir, I'm not sure.
Yeah, almost nothing about thiamine. It is almost always a concern that we may not be effectively handling it, but that is okay. I'm not going to be saying that it is going to hurt somebody, so you can give it if you want to. But is there a need to give sugar in this day and age? Almost never, no? You can always do a CBG. You can always do a CBG. It is a distinct possibility that the patient may be already hyperglycemic, which may be a component of his coma. So right now, much of the things about the sugar and the vitamins is really something that we debate because there is no evidence one way or the other. But the other two, the flumazenil and naloxone, have become a very contentious kind of a debate, and I will try to explain that a little bit in detail at this point. Okay, let me just go back through the slides. Okay, so if I was to look at it, the classic coma cocktail came from an era where the belief was if the patient was comatose, they will probably stop breathing. Okay, and you might have seen it in all your movies. When somebody is poisoned or something like that, somebody will say, stand there, slap him a few times, keep waking him up. Okay, the idea of analepsis, of keeping a patient awake, is very old. It started with the use of caffeine, theophylline, you use strychnine, nicotinamide. I don't know whether you guys have ever used nicotinamide.
No, sir.
Way back when I was a medical student, some of the things that we gave to anybody who was comatose, okay? The idea of using analeptics to awaken a patient so that they will continue to breathe, okay? And that is the basic idea of this coma cocktail. So along those lines, in an era where you don't measure dextrose, and one potential concern that you had is before you could do a bedside, what do you call your finger prick blood glucose on these patients.
Yes, sir.
We would probably be guessing about what the dextrose value is. And it was very safe under those circumstances to say, let's not keep the patient hypoglycemic. Let's just go ahead and give them the glucose.
Yes, sir.
And along those lines, people started worrying is that if you're going to be giving glucose to a large number of patients who have a thiamine deficiency, that you may probably be worsening the situation. So somebody added the thiamine to it. But the classic analeptics of the past were all the drugs that we don't have any use for. The modern analeptics that we introduced later were naloxone and flumazenil. Okay, and you can go off and I will continue with this. Okay, so effectively, why is naloxone used? Obviously, it is a competitive receptor blockade. And what it does is it has the ability to have a reversal of some of your opioid effects without causing the respiratory depression that you would expect under these circumstances. Okay, so when you're looking at the studies that use naloxone effectively, the fact of the matter is, and look at these numbers, okay,
Yes, sir.
roughly, you don't have to, you can turn off your mic right now, okay. So the fact is very clearly in most studies, you will notice that the majority of patients with opioid overdose who are given a naloxone will have a reversal of their coma and their respiratory depression, almost guaranteed, okay? And the number needed to treat, as we can calculate, is roughly 1.2. That is 85% of all these patients will revert. So for every 1.2 patients that you give this medication to, one person will wake up completely. Okay, that is a very effective kind of an option that we will see. All right. But the concern has always been, what about the adverse effect? Will that induce some kind of a withdrawal reaction in these individuals? And the frequency of withdrawal reactions is very low, roughly only about 8%, or roughly you need to treat 10 times the number of patients for you to have a withdrawal reaction, in contrast to the number of patients who will awaken. So if you really look at it in balance, the benefits of naloxone when there is a consideration for an opioid overdose, and this is the example, in this particular study, they gave it when there is history of parenteral drug use. The patient was hypopneic with a low respiratory rate, had a low GCS and clear meiosis, but the clinical pattern was strongly compatible with an opioid overdose. It seemed very logical to go ahead and give the naloxone under these circumstances. How about flumazenil? Okay, and flumazenil, again, when you look at it, in patients with a suspected benzodiazepine overdose, the meta-analysis will show you a very similar kind of benefit in terms of arousal from a coma. The number needed to treat there, I said, was only one every 1.2 patients. Here is 2.2 patients. That's not too bad at all. The fact is, 1 out of every 2 patients that you treat will wake up when you give them flumazenil, even if it is transient, okay? So half of them will definitely wake up. And the concern that we have about an adverse event will be reasonably small. Again, for you to develop any adverse event, the number needed to harm, as we say, it's mainly your concerns about the development of seizures, okay, or arrhythmias, okay. When you look at that, the numbers that you need to treat for you to harm such an individual is very, very small. Again, like in the other situation, if you look at these two numbers, they're exactly identical. That is, you benefit from the administration of naloxone when you're suspecting opioid overdose. You benefit from the administration of flumazenil when you're suspecting a benzodiazepine overdose. The adverse effects in both of these circumstances is relatively low. So you would anticipate that when people are using the modern coma cocktail, that both these drugs would be probably recommended. But what is very interesting is most recommendations will say, if your suspicion of opiate is very reasonable, use naloxone. But if your suspicion is of benzodiazepine, do not use flumazenil despite the so-called efficacy. Why is there this huge selective bias for the selection? Okay, one thing is very clear. Nowadays, nobody recommends that you use dextrose, especially when you have a glucometer that is available, that you use it on an as-needed kind of a basis. But when you're considering these other two drugs, there is an empirical recommendation for the use of one and a recommendation against the use of the other. And we need to understand why this is happening. And this is because the way in which the opioid works is not by awakening the patient. I mean, the naloxone works is not by awakening the patient, because naloxone today is not recommended in the old doses that we were using, that used to be about 0.4 milligrams. Now the recommendation is to go with much smaller titrable doses of naloxone that will allow an initiation of respiration without analepsis, without waking up the patient, because waking up the patient will be associated with a greater tendency for withdrawal. And so the argument is a titrated small dose of naloxone repeated appropriately can be an essential component of a cocktail when you're suspecting opioid overdose. But in flumazenil, for it to be effective, you also need to have the patient awaken, and the chances of a withdrawal reaction with benzodiazepine awakening and potentially even provoking seizures, especially if the patient has co-ingested other agents, is very high. So in general, the value of flumazenil has been something that people will say, don't even consider using it, even if you have a suspicion of a benzodiazepine. If the patient's airway is poor, protect it and go ahead and support them till they are aroused from that. But if you are concerned about naloxone alone, you can certainly use it appropriately to stimulate the respiration without worrying about the fact that you can get a withdrawal reaction. This is the kind of approach that people use. But remember, under our circumstances, we are not America. We are not luckily in a situation where opioid overdose has become rampant. And as a consequence, with very few exceptions, there are some areas in Chennai, I know, where frank opium is still used. With very few exceptions, unless I knew where the patient came from, neither flumazenil nor naloxone is what we use. We don't give dextrose on a routine basis. If we give dextrose, yes, most of us will also give some thiamine at the same time, primarily because it is not something that is going to be harmful. But what we should recognize is the ideas of these coma cocktail came in an era where the focus was on analepsis and waking up the patient, which is probably not such an important aspect in modern intensive care, primarily because we can provide appropriate respiratory support even without waking up the patient. And that is what we need to be very careful about. Okay, so along these lines, as we already said, as far as the coma cocktail is concerned, the analepsis is not the primary goal. So most components of the coma cocktail are probably not something that we would even focus on. Okay, and as I said, neurological support must be appropriate, with glucose being adjusted and treated according to a glucometer reading rather than empirically. Now, we need to understand that many of these situations, seizures will be provoked, but in many of these kind of situations, the treatment of choice is certainly not your phenytoin or barbiturates over these conditions. The benzodiazepines continue to be the first choice for either a seizure that is associated with the medication or with the withdrawal of the medication, with propofol as a second-line agent. Most people would not use phenytoins or barbiturates because, again, it's going to be a short-term requirement and you don't need to continue with the anti-epileptic medication for very long periods of time. There are two very specific situations where you need to look at a different way in which you would handle the seizures, and that will be classically in tricyclic overdose. Which is the best indicator, and this is not a question that I've already put in over here, but which is the best indicator of neurotoxicity, of development of seizures in a patient who's taken a tricyclic? Can anybody answer?
You can unmute and answer, others can type.
One person can unmute and answer. Which is the best marker of seizure potential in a patient with tricyclic overdose?
Dr. Sandhya, you can unmute and talk. Dr. Sandhya? Dr. Sandhya, you can unmute and talk. Or anyone else?
Anybody else? Don't pick on people, Anup. Most people are trainees, I suspect, right? Or if they are active professionals.
Yeah, professionals are also there, sir.
Oh, there are. Okay.
Yeah.
Okay.
Please unmute and talk. You can give an answer.
Sir, ETG change, sir, QT prolongation?
Not QT prolongation. I
The
know.
ECG changes.
I can tell you, is that Pratik who's giving the question answers?
Yes, sir.
I knew that. Okay. Wrong answer, Pratik. Sorry. What is it? It's the QRS width. Okay. It's very interesting, but the QRS width, it is very important. The QRS width is both an indicator of neurotoxicity and cardiotoxicity in tricyclics. That's a side question. And then last and interesting point that I talk about in seizures is for INH toxicity, large dose pyridoxine is probably the most appropriate antidote under those conditions. There may be, again, a need for you to individualize the management of the patient, and occasionally neuroimaging and NLP may be necessary, especially if you have a superimposed concern about a non-toxicological kind of a circumstance. Okay, so with that sort of settled in the initial phases, I want to focus on some gaps. Okay, this is my favorite cartoon character. I love the gap in his tooth. Okay, so if somebody wants to answer this, it's a rather facetious kind of a discussion over here. But I want to say, anybody wants to take this and look at each of the sections and says what they feel about it.
So I would like to speak.
Yeah, sure.
So the question is, the anion gap should only be checked if the patient has acidemia, is only seen in 4 intoxication: methanol, paraldehyde, ethylene glycol, and salicylate. If present, is an indication for bicarbonate therapy. How and who cares? Sir, so basically anion gap.
So you say I will throw out 4. I do care. Okay, thank you, and then go on. Okay, number 1.
First thing is like the anion gap depends whether it's a positive anion gap or a normal anion gap. Depends upon that
Now I'm asking you a question. I'm asking you a question over here. Should be checked only in a patient with acidemia? So if the patient comes over here, the pH is completely normal. Would you check an anion gap or not?
Yes, I will check, sir.
Why?
Might be patient is in compensatory phase.
Absolutely, which is very typical that many people make that mistake and say, oh, patient has no acidosis, therefore I will not check the anion gap. No, the anion gap is a good way to give you a revelation of the existence of an underlying acidosis in a patient with a compensated pH or with a complex disorder where the pH is a little bit difficult for you to interpret. So you're completely right and saying that you should check an anion gap. So when you're looking at a blood gas, particularly under toxicological circumstances, always calculate your anion gap. Okay,
yes,
so that is very fair. And the next one, it's seen only in 4 intoxications, the large anion gap.
Yes, sir.
The large, I meant large anion gap, so I didn't put anion gap alone.
Yes, sir.
Is that
positive anion gap? So normally we use as a mud piles as a it's like acronym. Acronyms for the positive gap.
Okay.
So there are other positive anion gap like diabetic ketoacidosis is also one of the things.
No, but that is not an intoxication. Among intoxications, are these the only 4? Because in mud pies, if you really look at it, methanol is M, U is for uremia, D is for diabetic ketoacidosis, P is for paraldehyde. Okay, yes, I is for infection, lactic acidosis, E is for ethylene glycol, and S is for salicylate. So we covered methanol, paraldehyde, ethylene glycol, and salicylate, right?
Yes, yes, sir.
That is the traditional error, okay? Because to think that only these 4 are the causes of an anion gap acidosis for toxicological reasons is is inappropriate, because a large number of other conditions will also create an anion gap, which will be either direct or indirect. So for instance, certain poisonings can create a hemodynamic insufficiency that can be associated with a lactate. It's very unfair, because when I say that, actually it'll be covered under the mud pies anyway. But we have to remember that you just don't say, oh, methanol, highly unlikely. We have not heard of any kind of a situation where recently there has been any methanol concern. Paraldehyde and ethylene glycol, we don't have access to it. And very few people ever consume aspirin in such large doses. So we don't worry about it. Not necessarily the only way in which we need to look at it. So we need to look at it a little bit more. Okay. And the last one, is it an indication for bicarbonate therapy?
Sir, depends upon the pH. According to the guidelines, if the pH is less than 7.1 with bicarb of less than 15. So that is a condition where we can consider about the bicarbonate therapy. Otherwise, it causes intracellular acidosis and it worsens the situation.
Okay, that is usually our argument. Okay, with very little evidence in one direction or the other. Okay, I would almost feel that I would relegate bicarbonate therapy to, as you suggest, to very low pHs. Okay, under those circumstances, and probably not on the basis of genuine evidence, but just based on our own fear. It is like our current COVID fear. Okay. I'm sorry to say that, but basically it is a reaction rather than a genuine kind of an action. But I think that is relatively unimportant. But to me, the value is more in the diagnostic kind of a direction. We all know what a metabolic, anion gap is. I don't think I spend too much time on that. And as you said, we traditionally will attribute it to our famous mud pies. Okay. This is a Mississippi mud pie. Have you seen this chocolate cake ever in your life? It is the world's best chocolate cake. Okay. So that is the mud pies that you need to worry about. But I wanted to show you that from A to V, there is a whole range of agents that can create an anion gap in toxicology. All right. So if you really look at it, it is not such a simple thing. It would probably indicate something has been taken, and probably would be a good way of judging whether the patient is responding either by eliminating this this set of agents or not. So this is almost a trivial pursuit kind of a question, because it doesn't really dramatically matter. It's not going to change the way in which you overall approach the patient. Okay, so let's go on to my favorite topics, osmolarity. Okay, so anybody wants to handle this? I love my illustration.
Yeah.
Anup, it's making me feel that I'm wasting my time over here. Okay.
You are tempting me also, sir, now.
Yeah, look at this, how nice and cold it looks. Okay.
Anybody like new persons can unmute. Dr. Sandhya, are you there? New persons like you have joined, like I've promoted. You can just unmute and talk. Please.
And also appreciate the humor of the question, okay? It's very important. Okay, if there's nobody there to unmute, I will just go ahead with the reading the question. You have some suspicion that your patient has co-ingested ethanol. It is not very uncommon, please remember that. Many people who come in with a toxicological problem may have taken something, but it is very common for them to have co-ingested other agents. And you have a suspicion that the patient may have co-ingested ethanol. So you ask your laboratory to give your patient's osmolarity of the blood. They call you back and they give you a result saying 310. Okay. So at the same time, you check the patient's sodium glucose bun and you come to a conclusion that there is no way that this patient has any alcohol in him. He is a good teetotaler and you have to go and apologize to him for calling him a drunkard. Don't call me a drunkard either, because right now I don't think I have any reason for this. Is there a flaw in this reasoning? And this is something that I want to emphasize very strongly. Is there a flaw in this reasoning? What is the reasoning that I'm focusing on? Now I need somebody to talk over here.
Yeah, please unmute and talk, please.
Any one person.
Yeah.
What am I trying to say with this entire slide?
Sir, can I speak, sir?
Yeah, please.
No, Pratik, you probably have heard me say this. Pratik used to be my trainee before. So if he's going to say that, it will be a biased kind of an answer. So I'll have to hold you off, Pratik. Okay?
Sir.
Yeah, I'll have to hold you. If you don't get the answer, I will be very disappointed. So I don't want to be disappointed right now. So I'm going to presume that you know the answer.
Others, like Shweta, are you there? You can unmute and talk.
Sir, I don't know, sir.
You don't know. Okay.
Okay, no, doesn't matter. You can sit over there and try and see. Let's just guide you through this entire thing, okay? And say,
Yes.
what is the aim of this entire exercise? I am trying to see if the patient has ethanol in the blood. Am I right?
Yes,
Okay?
sir.
And I don't
Yes, sir.
have the toxicological assay to know whether there is ethanol or not, right?
So we have to calculate the
what-
serum osmolarity based on the
Exactly.
values given,
No,
and then
so what
check if there is a discrepancy. Yes.
So what I am presuming over here is that if I
Yes.
measure the osmolarity, a change, the alcohol will change the osmolarity and give me an
Yes.
answer whether the patient has it or not. Okay,
Yes, sir.
so I ask the lab to give me their osmolarity. So they
Yes,
give
sir.
me a value. Okay,
Yes, sir.
and
Yes, sir.
I also will run a calculation over here. Okay, So
Yes, sir.
normally the osmolarity which you calculate is based on your sodium, your glucose, and your blood urea
But-
nitrogen,
Yes, sir.
as
Yes,
long as there is no extrinsic osmol. Am I right?
Yes, sir.
Okay, so on the basis of this, sodium times 2 will be 290. Glucose
sir.
divided by 18 is going to be 10.
10. Yes, sir.
And BUN divided by 2.8 is also going to be 10.
10.
So
Yes, sir.
roughly, so 290
Around
plus 10 plus 10, 310.
310.
Exactly.
Yes, sir.
Okay,
Yes, sir.
so according to this, I'm getting both the osmolarity that the lab gave and
Yes, sir.
what I'm calculating is the same.
Yes, sir.
Okay.
Yes.
Okay. And I presume that there is no quote unquote osmolar gap. Am I right?
Yes, sir. Yes, sir.
So am I presuming right? Because most labs, and you check it with your lab, okay?
Yes, sir.
If you
Yes,
ask
sir.
them for an osmolarity,
Yes, sir.
do they measure the osmolarity?
No, sir.
Aha.
Maybe they calculated.
No, they also calculate it.
Calculated. Yes.
They
sir.
also calculate it. So you need
Yes,
to
sir.
ask them, and then they'll say, easy, sodium by so much plus glucose by so much plus BUN by so much, and we'll give you the answer.
Yes, sir.
Right? So
Yes,
that
sir.
is the flaw. In
Yes, sir.
most Indian laboratories, when you ask them to
Yes.
give you an osmolarity, they will calculate from exactly the same numbers that you have. Okay?
Yes,
So
sir. Yes,
the
sir.
distinct possibility that something was not done. So
Yes.
the question that I'm going to ask you is, how do you measure osmolarity in contrast to calculating it? And I have an answer over here that will be saying, how can you remove snow and ice without using a shovel to remove it?
Melt it.
Melt it.
Yes,
Yes.
sir.
How can you melt it? Set
Heat it.
fire to it. Heat it
Yes,
is
sir.
one
Yes.
brilliant option. But other than that,
Evaporate.
no,
Vaporize.
evaporation is okay. That is the same as heating. Okay.
Yes, sir.
I'm really involved
Pressure.
in this beer. I'm really putting a lot of beer everywhere. Okay. What other option? If you had lived for a while, say somewhere in America or something like that, one of the
Yes.
first things that you will notice as soon as the snow comes in, they will
Yes.
have large numbers of trucks that will go on the street salting
And
it.
shovel. Salt it.
No, no shoveling, salting
Okay.
it. Why
Okay, sir.
does salting work? So you tell me the reason. How will salt work? Have you tried it? You just go to your refrigerator and
Yes,
sprinkle little salt on in your freezer and see
Okay.
if it actually melts it. You don't have to go now and test it, but I promise you it will
Yes.
work. So why
Yes,
does
sir.
it work? Why does it work?
It actually dissolves in the water, sir. But,
Yeah.
yes.
Yes, it
So,
dissolves in the water, and
the
therefore,
water. The
therefore,
volume decreases.
volume. Why
No,
would the volume
not
decrease
volume.
when you dissolve the salt into
No,
water?
no.
Now, what else will it do?
It increases the
You're talking about-
osmolarity. It increases the
Absolutely.
osmolarity.
An
Yes, sir.
increase in the osmolarity will do what?
It will melt the.
Why would it melt? Because it depresses the freezing point.
Yes. Okay. Yes, sir.
Water freezes at a specific temperature, okay,
Correct.
under
Yes.
conditions.
Yes, sir.
If you lower the
Yes.
freezing point at the same
Yes,
given
sir.
temperature, it is going to melt, okay?
Yes.
And that
Yes, sir.
is the basic idea. The osmolarity of a solution, which is basically the solution with salts dissolved in it effectively, is
Yes, sir.
going to have a depression of its freezing point based on the osmolarity. Okay?
Okay. Okay.
And
Yes,
one of
sir.
the ways in which you can measure osmolarity is to use what is called a freezing point osmometer.
Osmometer. Okay, sir. Yes,
All
sir.
right? Okay,
Yes,
this
sir.
is just fun in education. I'm not trying to tell you anything, but I want you to
Yes, sir.
understand this component very, very clearly. So
Yes,
if you had a true measure of the osmolarity independent of the calculated osmolarity and demonstrate the existence of a gap, then
Yes,
you
sir.
can say that there is an extrinsic osmolar substance.
मैम
Yes.
अभी वो वेबिनार सुन रहा हूँ.
Hello? So somebody else is saying something. Okay, but did you get this broad idea? Okay, so I think we need to understand this, and this is a very common problem. For you to look at the osmolar substances, there's a whole range of osmolar substances that you can expect. Ethanol, ethylene glycol, glycerol. very classically, if your neurosurgeon still continues to use glycerol or mannitol for the reduction of their ICP, don't be surprised by the fact that the patient may have an osmolar change, okay? And sometimes even that won't be expressible because you might see a sodium declining on those patients, and there will be, unless you measure the osmolarity, you'll never know it. So this is something that you should be very clear about understanding. So the second gap, the first gap that we talked about was the anion gap. We got some ideas related to the anion gap. The second gap that we talked about is the osmolar gap. And now I'm going to talk about oximetry. Who wants to take this question right now? This is a very different kind of a question. Anybody can do this. Anup, you're still there?
Yeah. Can only Shweta is there? Can anyone else? New person? I like. Yeah. I've added one more person. You can unmute and talk.
Anybody. The fun is only in the unmuting.
Yeah, please talk. Yeah, so many persons are raising the hand, but the person who was unmuted, you can talk. No problem.
Just try talking. If you're heard, you're here.
This is a case where patient with unknown ingestion is being routinely evaluated. Vital signs are... Hello?
Okay. Yeah, go ahead.
Vital signs are currently stable, but saturation is 85%. What is your diagnosis if option A, on placing him on increasing O2, including NRBM, his saturation hovers at 85%. Option number 2 is if
no,
the
it's
arterial...
not option. No, I'm not giving you this as an option. I'm giving you as the three things that happen when you place this patient on oxygen. Okay, number one, you're placing him on increasing amounts of oxygen and his saturation remains at 85. And then you're measuring a blood gas in the same patient. When he's on room air, his PO2 is 80. And when he's on high arterial PO2, NRBM, his PO2 is 360. So what is this condition that you are seeing right now?
It can be methemoglobinemia.
Okay. So how do you describe, you describe what will be the classic features of methemoglobinemia?
Classic feature will be patient will have saturation, even with high oxygen supply, patient SpO2 will be low, but on ABG, PO2s will be more than 60. The diagnosis can be confirmed by oximetry values on ABG.
On the ABG, what you're detecting under those circumstances, you'll see a difference between the pulse oximetric saturation and the co-oximetric saturation, which is going to be on the blood gas. I've not mentioned the co-oximetric saturation, but the fact that the patient has a reasonably normal PO2 means that his oxyhemoglobin concentration is going to be very reasonable. Am I right? So if you really look at it, there is going to be a huge gap between the pulse oximetric and the co-oximetric saturation, what we would call as our third point, the third kind of a gap, an oximetric gap, as you might want to use it as, okay? So with an oximetric gap, and this particular kind of an oximetric gap, you're seeing is classic of methemoglobinemia. Can you give me a reason why methemoglobinemia will show you that? Why is it that the co-oximetry or pulse oximetry remains flat or unchanged?
Don't know, sir.
Don't know. Okay. We'll come back to that. Okay. All right. Can you give me the last answer to this? Predict the direction of his saturation if he's given a definitive therapy for this condition. Since you already got the diagnosis as methemoglobinemia, what is the treatment? Methylene blue. Okay, so I'm going to inject methylene blue in this guy. What will be my direction of his pulse oximetric saturation?
It will improve.
Have you done it?
Yes, sir. One time I have done it.
And it improved immediately?
No, after I gave 2 injections, after 20 to 30 minutes, actually it improved.
What happened during the 20 to 30 minutes that you gave it?
It was almost static.
It was static. Then you didn't give methylene blue. Or you didn't give an adequate enough dose of methylene blue. Very typical. It is a classic blue dye, right? And when it goes into your circulation, it actually causes frighteningly low saturations. Okay? It is a complete interference that it will create, and it will give you a wrong kind of saturation. And as it gets washed out of the bloodstream, when the methemoglobinemia improves, you probably will see an improvement in the saturation. Okay, but just as an idea, this is very typical that when you're giving the methylene blue, and do you use methylene blue for any other condition? Can you tell me? Besides methemoglobinemia?
Refractory shock.
Refractory shock, what they call a super refractory shock, where you've already gone on to high levels of every other agent and then methylene blue. Very recently, our friends are also using vitamin C, okay, which has been not shown to be true. There is no data on methylene blue either, but that is something that we can always use, but I wouldn't probably recommend that because there is no data to support its use. But thank you for remembering that.
This concept is important now because so many people believe that in COVID, the hypoxemia is because of hemoglobin damage.
Okay, so they're giving the methylene blue nowadays?
No, not like that. The concept of the gap, no. Like,
yeah, okay. Okay.
Suppose, if that was a like toxicity, that would have been, there would not be like arterial oxygenation should have been normal. You might have seen that WhatsApp, the message spreading.
Yeah, I'm not a very avid attendee on WhatsApp University at the present time. So I'm certainly not very familiar with it, but I can think of the illogical approach that people will use. Anyway, so we will leave COVID for a little while. We are right now on a COVID vacation. But what I illustrated in these three situations is the three major gaps that we need to be looking at in toxicological problems. The anion gap, to give you clues as to the existence of a toxic agent, the oximetric gap, and the osmolar gap will give you some additional clues that you need to evaluate these patients. The basic idea is a wrong idea that when we look at pulse oximetry, we believe it is almost the equivalent of co-oximetry, which it is not. The fact of the matter is there are a lot of factors that interfere with the measurement, particularly to create a lot of refraction of the light. And it is very unlikely that you can get a true absorption frequency that can give you an estimation of what is happening in these RBCs. So as a consequence, most pulse oximeters are not based on an absolute measurement, but basically they're based on a ratio of absorption of lights at these two different frequencies, from which you can derive the saturation of oxyhemoglobin by measuring it against a sample group of patients. So usually they take a large number of volunteers and then they look at the association between the oxygen saturation on the given patient directly measured through co-oximetry and the ratio of absorption that you get on the pulse oximetry. And interestingly, the ratio of absorption of 1 correlates with 85% saturation. And if you really look at it, methemoglobin, which has a ratio of absorption between these two light frequencies that you use in the pulse oximeter of exactly the same value of 1, usually will seem to push the oxygen saturation towards 85%. So irrespective of whether the oxyhemoglobin goes up or low, if you have a sufficiently large amount of methemoglobin in your blood, you're going to keep your saturations trending towards 85. It won't be exactly 85, but it'll be trending towards that, creating this so-called SpO2 difference between your co-oximetric and your SpO2 saturations. And that is probably something that we need to do. Okay, this is just another idea that we need to know on pulse oximetry. That carbon monoxide poisoning, which if you're worried about a smoke inhalation, can give you a false impression on the pulse oximetry because it is going to be read as being a normal or oxyhemoglobin, which again will give you another kind of a oximetric gap. So the basic idea, again, mind the gap. I don't know, have you traveled on Chennai Metro? Right now it is off on a holiday, but the Chennai Metro also has this mind the gap kind of an issue. If you put your foot between the two, you're going to get into trouble. So if you want to get out of trouble when you're managing your toxicological patient, please be very careful about these three gaps that you have. The last aspect of it, and this is something that I think Anup especially wanted me to emphasize, is the issues related to elimination of the toxin. Okay, So I'm going to give you an example over here. And let's just, I want one more volunteer under these. Volunteers, please, hands up and open mouth. We got another 15 minutes and I need to finish it off by then. I have 10 questions and that many slides. 10 questions means 2 more questions. Volunteers, yeah, somebody is turning on the mic, please.
I think your Pratik, we can give a chance this time. Every time he's attempting.
Pratik is my former student. As long as he was my student, he never came to my talks. So I don't know whether he wants to do that. Okay, he's very welcome to do it. Go ahead, Pratik. Go ahead.
Pratik, you can talk, no problem.
Sir, can you hear me, sir?
Yeah, please.
Unfortunately. Yeah, go ahead. Go ahead, go ahead.
Sir, making me nervous. Sir.
Naturally.
No, he's not like before. He is very cool now. That's why he's showing all here and also. Don't worry.
Go ahead, go ahead.
A 33-year-old nurse has consumed more than 15 grams of paracetamol 3 hours ago. You plate an NG and a lavage.
Okay. Listen to all of this and be very clear. Number one, is it a toxic dose of paracetamol? Absolutely. When was it taken? 3 hours ago.
3 hours ago.
Yeah. Then you place an NG
tube and lavage with no pill fragments removed in the aspirator. Your senior walks into the ER and accuses you of unnecessarily placing an NG tube for lavage, and too late at that. Says that if you actually wanted to lavage, you should have used that evolved tube, 28 gauge as fat as an ETT. Ask you to verify if the tube is in the GIT by X-ray, and if it is in the correct site, to give 50 grams of activated charcoal anyways. Is he just pulling his weight around, or some of his statements are statements and suggestions valid?
Okay. In the place of the senior, you can put my name, and in the place of the one who you are the one who is placing it. So I came here and said, hey, you so and so, why did you put an NG tube at 3 hours after the patient has ingested all of this? Is that an acceptable question or wrong?
Sir, acceptable, sir. After 3 years, it has no value, sir.
No value for what?
So for lavage and for getting the paracetamol removed.
You're breaking up a little too much. Okay. So for lavage, it doesn't work. Yeah, absolutely. Okay. Then what about removing the particles if you're going to get it out? Have you ever tried removing pills through a nasogastric tube, through a Riles tube?
No, sir. I've never. No, sir.
You need, even if you put anything, then nothing is going to come out through that. The usual recommendation for a gastric lavage, if you're going to do it early enough, is you need to have a very big tube. The evolved tubes are the best way to get it out, but it is potentially has its own adverse effects. So that is also a correct statement. The first two statements are correct. Then he asks you to verify if the tube is in the GI tract by X-ray. Can you do it clinically and be happy?
Sir, ideally confirmation is done by X-ray, but clinically we can do it, sir.
No, my own argument is for aspiration, I don't mind if you leave it without an X-ray. But if you're going to administer anything, would you need an X-ray?
Yes, sir.
Absolutely. So he's going to give you a recommendation of giving 50 grams of activated charcoal anyways. Do you agree with that or disagree with that?
Disagree, sir. Only N-acetylcysteine we have to give, sir, nowadays.
Nowadays? In the past, we used to give charcoal also?
Yes, sir.
Okay. All right. So your answers are like this. You agree with the fact that a nasogastric tube is inadequate, especially when it is placed late. You think that a larger tube would be worthwhile if you had placed it early enough. Evolved tubes are valid, but again, they carry their own risks. You also agree that you need to verify it with an X-ray before you administer anything, but not necessarily for other reasons. And the last thing that you would say is there is no role for the administration of activated charcoal. Because it's a paracetamol overdose, you would rather give N-acetylcysteine. Very
Yes, sir.
logical and very appropriate at this point. But I'm going to go through this a little bit more. Okay, very, very clearly, we need to understand there are certain traditions that we have had about decontamination of patients with poisoning. The classic use of emesis in an era where we don't have ipecac ever available. I have seen people give large quantities of salt to induce emesis. Okay, and please be very careful. Emesis is not a good thing to be induced, and particularly salt that they give under those circumstances. I've seen patients come to me with sodium levels of 190 and dying of the salt ingested rather than of the poison that they had ingested. Okay, so there is no indication for emesis, and emesis with ipecac or salt can predispose the patient to aspiration, and something that you would like to avoid altogether. If you're going to do a gastric lavage, the usual data that you have is preferably to do it within the first hour after the ingestion. And for this, as I said, you may need an EVAL tube that is very large. And more commonly, if you need an EVAL tube to get the gastric lavage done, you probably also need to protect the patient's airway, which I think is a completely avoidable ritual with very few exceptions. So we probably shouldn't be doing gastric lavage, I would say, with an exception. So somebody comes to you with an OPC poisoning, is smelling of petrol, some kind of a solvent in his abdomen. Would you put a NG tube and aspirate? Pratik, if you're still there.
Yes, sir.
Would you?
Sir, I could not get you.
So if a patient comes to you with a organophosphate poisoning.
No,
okay,
sir, not in organophosphorus, sir.
You won't try and give him a gastric lavage.
No, sir.
You won't even try to aspirate the solution from the stomach.
No, sir.
I would feel a little uncomfortable about it because absorption can still occur. If I feel that there is a certain amount of solvent in the stomach, I can expect that there will be also the poison in the stomach. It may be worthwhile going ahead and doing that. I wouldn't try a lavage. I would certainly try to aspirate it. Okay. Again, this will be the kind of exceptions that we need to make, not to put in on a very routine basis, but to be selective about the way in which you would use it. And the last kind of a situation where people use so-called bowel irrigation has got very definitive indications. Okay, when you're using polyethylene glycol, you give it in large enough quantities that you provoke a persistent enteric elimination, which means the patient should have multiple bowel movements and watery bowel movements for that to be eliminated. It is used very specifically under the circumstances that I've listed over here, and it is not a routine part of therapy. So if I look at it, emesis is not recommended. Gastric lavage, if it is done early enough, will be worthwhile, but with very few exceptions, you may extend it a little bit. And bowel irrigation is again got very definitive indications that most of the traditional decontamination methods are probably irrelevant. And we always would like to ask the question, should we be adding activated charcoal? In this particular situation, in this example that I gave you, you said Pratik didn't want to give
no, sir.
Activated charcoal. Okay, let me just go through some of the arguments about activated charcoal. Activated charcoal, as you realize, is basically charcoal, which is any kind of a combusted material. It can be from wood or from bone or whatever else. Then you activate it by taking off the pre-adsorbed material that is there to increase the surface area that you can have in terms of contact. The surface area that you give is so huge, as I would almost argue that 1 gram per kg that you give 50 to 60 grams of activated charcoal is almost the same as having an entire Wimbledon in terms of the surface area that you have. It's a huge absorptive surface area. Okay, and when you really look at it, the consensus is very clear. You would consider it in severe poisoning where it is less than 1 hour duration with some relaxation one way or the other. The traditional dose will be to give 25 to 50 grams, 1 gram per kg body weight is very typical with one single dose. We do not give sorbitol. In the past, we used to worry about the activated charcoal causing constipation, so they used to add sorbitol, but all we notice is sorbitol only increases the risk of emesis. Okay, and even under those conditions, when it is given less than 1 hour, okay, The adsorption is very unlikely if it is certain agents like your alcohols, organophosphate, hydrocarbons, etc. will have absolutely no adsorption, and you probably should not be using it definitively in all these kinds of conditions. But surprisingly, when you really look at it, the reported complications related to the use of activated charcoal are at best extremely minimal. No ulceration has been reported, no constipation has been reported. Hemorrhage is very unusual, again with the single dose. Okay, so if you really look at it, the general safety of it is very, very good. And for most people, very freely on the basis of this, activated charcoal is something that most people will say, I can't give. Nobody comes within 1 hour of their dosing, and it doesn't make any kind of sense for me to go ahead and give it. So some people would use multi-dose charcoal, which has got a completely different mechanism. By being in the gut at all times, it can cause an adsorption of enterohepatically circulated poisons. So typically theophylline, many of these anti-seizure medications, and to some extent things like digoxin can also be circulated through the liver and into the gut, and can be a way in which you can minimize it. But now I'm going to throw a bomb at you and say that in this particular case of paracetamol overdose, there is a certain amount of data that will come up. Before I go on to that, okay, the two large randomized controlled trials on multi-dose activated charcoal is both from Sri Lanka. The first one saying that actually there was a reduction in mortality when you looked at it with yellow oleander poisoning alone. But there was another subsequent trial, which is part of the large Edison trial related to organophosphate, etc. They couldn't show any kind of a change in mortality. So multi-dose charcoal. So every piece of evidence went against that. But as I was saying, I'm going to throw a bombshell at you and say the exception is clearly paracetamol overdose. Okay, very typically, most people would say, if you can give a gastric lavage earlier than from 1 hour from the overdose, you can do it. But you can give an activated charcoal under these circumstances for a much longer period of time. The data comes from no randomized controlled trials are not existing, but there are large observational studies that seem to imply a lot of things. RCT of decontamination activated charcoal led to a decrease in paracetamol levels in contrast to just routine gastric lavage or emesis or no treatment at all. So number one, activated charcoal reduces your paracetamol levels. Okay, when activated charcoal is given before you give the N-acetylcysteine, there is a lower amount of liver injury. Okay, when activated charcoal is given up to 2 hours, the need for N-acetylcysteine is actually completely reduced. Okay, and if it is given even greater than 4 hours post ingestion, it is associated with lower ALT levels, particularly in patients with paracetamol overdose. And then one very large study of very serious toxicity, very large doses of paracetamol showed a reduction in hepatotoxicity when it is given within 4 hours. So in this particular example, where I've taken up to 3 hours, it may be the exception where activated charcoal is beneficial in toxicological situations. I don't have any data on any of the rest, but since this is probably one of the most common kind of poisoning that you see in the Western world, there is a reasonable amount of data to support the role. And activated charcoal does not interfere with the administration of N-acetylcysteine. So Pratik, again, yes, your knowledge has been updated. So it's a little bit of a change. So in general, when you look at most of the options that you have for the treatment, for the elimination, or for the avoidance of absorption of these varying agents, okay, we find that neither gastric lavage nor activated charcoal nor an aspiration or induction of emesis is useful. But there are clear exceptions over here, and I would put the exception of paracetamol poisoning into perspective over here. All right, the last one is about extracorporeal experiences. Okay, all right. So let's just ask you a simple question. There are different kinds of extracorporeal devices, like there are different cars. Hemodialysis, the Ambassador, hemoperfusion, the Corolla, and plasmapheresis, my Maserati over there. Okay, so which of these would you use, the Ambassador, the Corolla, or the Maserati for each one of these toxicities? So anybody can just take it and say, methanol, I'm going to use hemodialysis, hemoperfusion, or plasmapheresis. Paraquat.
Hemodialysis.
Now let's start. No, who's that? Pratik again.
Sir,
Pratik,
hemodialysis, sir.
is that Pratik again?
Yes, sir. Sir, hemodialysis, sir.
Shut up, shut up. This is not your question.
Okay.
Okay, can someone else take the question? Thank you.
Others, please.
Somebody else take it.
Shweta, you can. Shweta, Gautaman, Dr. Sandhya, Sriram.
Many of these names sound like people I know, so I hope it's not. If they are people I know, they will shut up. Okay. Pratik is the only one who puts his foot in his mouth and gets it stuck. Okay, who wants to do that? Methanol. Some of the people who answered early, who did pretty well, can also come back and can answer right now if you want to.
Unmute.
Anyone else? Just take it one at a time and then tell me which is your preferred method.
Please unmute and talk, please.
Yeah, this will be the last question, then we'll get out of here. Question 10.
Yeah, please talk.
Go ahead.
So methanol, I will prefer hemodialysis.
Okay.
And for paraquat, I will prefer hemoperfusion.
Hemoperfusion.
Drugs with high protein bound, both might not be effective.
Which one would you use? None of them would be effective?
Yes, none of them will be effective.
Okay.
Fourth is drugs with high protein binding, low volume of distribution.
I
don't
something.
know, sir.
Okay.
4 and 5, I don't know, sir.
4 and 5, you don't know. Okay. So the first one you said was hemodialysis. Completely acceptable. Methanol is a highly water soluble, non-protein bound substance that can easily be removed by hemodialysis, right? So you completely agree. That is easy to take it out. The second one, paraquat, as much as we worry about the fact that it creates a serious toxicity, it is very easy to eliminate it with the hemodialysis. Okay. The whole problem, unfortunately, is what the damage that it has already created, and it takes a long time for that toxicity to wear off. So it doesn't make any sense. I've seen people saying, oh, let's go ahead with plasmapheresis under these circumstances. It does not make any sense. Paraquat is as easily dialysable as the methanol would be. As far as the drugs with high protein and fat binding are concerned, a process such as a hemoperfusion, hemodialysis will not remove them. But a process of hemoperfusion will allow you to remove some of them irrespective of what the binding is. So that is usually the recommendation. The third one I put in because there are certain substances that can be bound very significantly and will have a very low volume of distribution that you can probably get them out through the pheresis. The reason is the volume of distribution will usually be, say, into the fat or into the tissues. And if the large volume of distribution exists, even if you take out the protein-bound process with the pheresis, you will have a redistribution from the other sources. So it is extremely important to recognize that the volume of distribution also makes a kind of a difference in selection. So drugs in category number 4 will be very amenable to plasmapheresis. But if the same high protein binding is associated with a large volume of distribution, pheresis will be useless because between pheresis episodes, there will be a huge recirculation of the drug. So that is what you'd like to. And one of the typical drugs that will be with a high protein binding with a low volume of distribution is the last one. The Amanita poisoning, the phalloidin that you have, which can be very eminently removed by plasmapheresis. So this is just to give you certain principles about the methods of extracorporeal support, primarily because with a standard hemodialysis machine, you can easily put in a charcoal cartridge and do some hemoperfusion. Many of us may have a little bit more difficulty getting pheresis done, but it also can be done. Okay, for most of us, we'll have access to these three kind of methods. And I think we need to understand the basic principles. We already talked about it. When you look at hemoperfusion, it removes the larger drugs, protein-bound drugs, and lipid-soluble drugs very, very clearly. But it has an adverse effect that can be related to the fact that the toxin can get saturated and there can be re-release, okay, that can occur, and thrombocytopenia. Besides that, you also have a major problem with electrolytes under those circumstances. Phosphate and calcium can be affected very strongly. For you, as far as your water-soluble drugs are concerned, standard hemodialysis is what you would probably like to use. Remember, all of them have the advantage of treating your renal failure, to restore your electrolyte balance and correct your volume status at the same time. Okay, just to give you some examples, methanol and ethylene glycol classically are dialyzable, though we don't have the option of the 4-MP that many people will have outside the country. We have a tendency to go ahead and dialyze when you have methanol intoxication associated with neurological symptoms or fundal changes that you will see. Okay, then in salicylates, again, it can be very dialyzable. Things like theophylline can work with charcoal hemoperfusion to some extent. So when you talk about plasmapheresis, you'll see a whole bunch of people that we will use it in. The ones in which, as I said, it can be very effectively used is in Amanita poisoning. But when you look at cisplatin and vincristine kind of dosing, these are all relatively rare. It is not something that you would probably use. Yes, it can be very effective in removing organophosphates, theophylline, and tricyclics. But would you be using it? It is frankly extravagant, because you have other options in the management of these patients. Theophylline, you can probably get away with the use of even charcoal, multi-dose charcoal, because gastric removal can be very effective. Or even for that matter, you can use, if you want to use charcoal hemoperfusion, it is very acceptable. You don't want to go on to pheresis. And you'll be stupid if you're going to use it in organophosphate. Okay, for tricyclics, you can enhance the elimination with not elimination, you can minimize the toxicity with the administration of a high concentration of sodium, either in the form of bicarb or in 3%. And it is definitely not indicated in paraquat. Very commonly, people would use it out of sheer desperation, and there is really no value. Talking about even greater desperation, use of ECMO, I have to put this in perspective. Don't look at the title of people who performed it, all my friends. Effectively, it is nice to talk about it. But as I say, it is sexy, but definitely unaffordable in terms of your treatment. Thank you all for listening. I think I will end my talk at this point in time. I hope I was a little entertaining, if not educational. And I hope that there were some points at least that were carried through. Thanks. I'm going to stop over here.
It was really educational, sir. Not only entertaining.
Yeah, that's me. All right. Hey, Pratik James still has his picture with me in it. Okay.
Okay.
All right. Any other questions? Any questions or anything else that was being asked?
Questions almost like all what we have discussed. Only one question, like, is there any role for steroids in any poisoning? That is the one question I've seen.
I've not seen in any poisoning that I know of. There have been people who continue to pursue it in corrosive poisonings, particularly in children. Okay, and I don't believe the data is supportive very, very clearly. So I would be very careful about making any recommendations. I can't think of any other indications that have used steroids in general. Steroids right now are the treatment for everything, including COVID right now.
Extended elimination, what is that any role in poisoning?
What is the role?
Extended elimination, he was asking.
I don't understand what is extended elimination. If somebody can just tell me what they mean by it, I'll be happy to answer it. Is this the use of IV bicarbonate or forced alkaline diuresis or things like that? Again,
like that, sir, yeah.
Many of those don't have hard enough evidence. Other than when you do forced alkaline diuresis, the biggest problem is the fact that you're giving large amounts of bicarbonate and at the same time inducing diuresis. All you do is you create major problems with electrolyte imbalances without any definitive benefit in terms of outcomes. Alkalinization, which we routinely use in tricyclics, works not because of the alkalinization, but because of the sodium that you're administering. Tricyclics are classically sodium channel blockers. And the sodium channel can be opened either by a large dose of sodium. You can use 3% saline, or you can use bicarbonate, either of them containing large amounts of sodium. And that's the reason that it is effective. It is not elimination under those circumstances.
Basically, membrane stabilization, no, sir?
Yeah, it is membrane stabilization with right amounts of sodium effectively.
Sir, I have a question, sir.
Sure.
Sir, what is your experience with aluminum phosphide poisoning, sir?
Okay. When you ask me experience, I always say I have no experience. I have basically very little aluminum phosphide. From all I've seen, every therapy that is used is anecdotal. There is really, the 1 or 2 cases that we've had 100% mortality. Okay.
Yes, so even we had 2 cases and it was 100% mortality, sir.
A lot of what people always talk about under those circumstances in terms of all the therapies that they use, I think are anecdotal at best.
Okay, thank you, sir.
Okay.
Sir, I have one more question, sir. Sir, last question. Sir,
sure.
What is the about vasmal poisoning, sir, which is very common in Andhra Pradesh? Hemodialysis, what is the treatment plan for?
Which one? The supravasmal thing?
Vasmal right? Poisoning, sir. Vasmal, sir. Yeah.
Yeah, that's the one which creates
hair oil vasmal.
Yeah, that creates that
yes, sir, yes,
facial edema.
Yes.
Okay.
Yeah, exactly.
Okay. But the associated toxicities I've seen, at least I'm not very familiar. I've not read it up completely, but the associated toxicities we see is almost negligible. What else does it create? Okay. We see a lot of airway edema.
Mainly airway edema and rhabdomyolysis, sir, causing acute renal failure.
So effectively what we have done under those circumstances, the rhabdomyolysis we handle with good hydration. There maybe we use a little bicarbonate, but not very convinced that is important. The biggest problem with rhabdomyolysis in any kind of toxicological problem is a severe underhydration that we give. The reason that they develop renal dysfunction, the renal dysfunction is not just from the pigmenturia that they get, but also because you're creating a huge amount of third space loss into the destroyed muscle. Okay, as a consequence of which the underhydration is the major problem. So adequate hydration with or without a bicarbonate would be the crux of its management and the avoidance of, if you need to dialyze, you end up with requiring to dialyze. But our general problem has been the airway edema is what we usually worry about. We do see it also.
Yes, sir. Thank you, sir.
Sure. Okay. No more questions, because after this I will start sounding dumber and dumber. So I desperately need to go and get my Stern. That's Tamil Nadu beer. Okay. All right. All right. Thank you all. And thanks,
thank you, sir. Thank you so much. And again, we expect you again, sir, with such excellent talks. Friends, sir will be with us again for many other sessions. We will finish some more topics in toxicology, then we'll be moving on to the hemodynamics. That's what sir has planned, and we'll let you know what are the other talks he's planning.
Okay, sure.
Thank you so much.
Thanks,
thank you, friends, and good night.
Okay. I can log out.